Hello, hello. Good evening, students. All of you from where we are streaming. Yes, yes, yes. Thank you very much. Thank you, all of you. Can I just get a thing whether we are audible to all and visible to all? Thank you, Mama Chan. Very good. I'm very good. Wishing all of you a very happy new year and a very successful new year. And what we are going to do. Thank you, Dr. Ashish, for having me on your channel. Thank you, the integrated channel, and thank you all of you. We are going to discuss the most important likely topics with MCQ. So slightly this is different from the previous streams what we have done. That in the previous streams I was only discussing MCQs with detailed explanatory answer. Here I will also be giving you certain theoretical topics. Okay, theoretical concepts also I am giving you. So it is going to be very useful. And after the theoretical concepts, we are going to discuss the MCQs. Okay, I want all of you to participate in the stream, make it lively, and I want all of you to answer and ask if you have any doubts, and definitely don't go home with any doubts. Okay, and before we begin, please share this video with all your friends and colleagues. Yeah, okay, thank you. Okay, and before that, quickly, all of you do follow me on Instagram, on OGGuru. Every day I'm posting lots of quiz. Do not forget to subscribe to my YouTube channel also, where there are many more videos in obs and gynae, and also join me on Telegram, where we are going to give the PDF also of this. So do not forget this. And definitely all of you, please get in touch with me on phone and WhatsApp on this number. I'm guiding the students. If you are preparing for this January FMGE examination, then you can just take my rapid revision subscription, where within one day, less than one day time. Okay, and I'll also put in the mic now so that the voice will become better. Can anybody tell me if the audio and everything is good, clear? Yes, but Anjali, definitely we are going to give the PDF also of the session. And do not forget to download the OGGuru app on App Store and Play Store. If you are going for App Store, the ORG code will be YYMSTV. Okay, and you can go for just the rapid revision MCQ discussion. It is 16 hours, but when you see at 1.5 to 2x speed, you just require 8 to 12 hours. Many students have subscribed to this course. They are really benefiting, and trust me, dear students, in just one day time, in 1 to 1.5 day time, you will be able to revise the most important, the whole subject of OBGY, which is a very scoring subject. Okay, so yes, virgin MCQ bhi karwayenge, Mohammed Ansh, don't worry at all. Okay, so I request all of you to subscribe to the OGGuru app, download the OGGuru app, get in touch with me, and just in 570 rupees, you can revise the entire gynecology in 1.5 days time. That is my guarantee. Okay, now the first concept or the first topic for the day is antepartum hemorrhage. Can anybody tell me how will the patient present to us? Any idea how will the... Thank you, Ajay. Thank you very much. Yeah. Yes. Anybody, when we talk about antepartum, short topics, ये सब जो आज 2.5 hours, 3 hours का stream है, all topics are extremely important and all are short question. Last time when I had done the session, so many students told me, sir, from this 2-3 hour session, there were 8 to 10 MCQs or more in OBGY. I'm hoping the same thing will happen. Yes. So can anybody tell me, yeah, RSR, but bleeding what? Bleeding in when? First trimester, second trimester, third trimester, how? So please understand, all of you, that when we have a patient of APH, the common thing in the MCQ will be bleeding in the third trimester. Please keep this in mind. Why? Can anybody tell me on the chat box what are the causes of bleeding in the first trimester? By the way, so I'm discussing a lot of things also. Okay, beta Rahul, you are confusing that's PPH. That's a PPH, beta. Rahul Pius, you are confusing it with PPH. Yes. Can anybody tell me some 1 or 2 main causes of bleeding in the first trimester? First trimester bleeding, what I have to keep in mind? Very good, Mohammed Anj. So first trimester bleeding, I have to keep in mind ectopic pregnancy or even a miscarriage, all the types of miscarriage or abortion, whether it could be threatened abortion, incomplete abortion, all that keep in mind. Very good, Anar Rajwade, and very good, Arya Suresh. Okay, so is this understood to all of you? Share this video with maximum all your friends and let us. So keep this in mind. Bleeding in first trimester, I have to keep of all these conditions in mind. Now in APH, when we have very good APH mein, we are going to have bleeding in the third trimester, and the two main conditions are placenta previa and abruptio placentae, abruption. Now can anybody tell me, can anybody tell me how will these two conditions differ? How will these two conditions differ? I'm also going to discuss in the next 5 minutes through MCQs the etiology of both of them, which we haven't discussed anytime on the YouTube. Yes. So can anybody tell me what is the main differences in the this one? Very good. Okay, so the important point is, sir, placenta previa is a painless bleeding, abruption is painful. And another important point, any student, another important point is that how is the uterus? How is the uterus? Can anybody tell me? Yes, very good, Joy. Tone of the uterus. Very good. Painless bleeding. Yes, yes, yes. So here, sir, the uterus is relaxed, and here the uterine tone is going to be increased. Uterine tone is going to be increased, and we will get either in the MCQ tender uterus, or if anywhere you get the MCQ tonically contracted uterus. Okay, if you get tonically contracted uterus, you can blindly mark abruption. Now, very important, can you tell me which condition I can wait and watch, which condition I should never wait and watch? No, beta. Fetal hearts we cannot say. Okay, no, vitals could be normal, not necessary, beta, not necessary, biomedics. Okay, no, no. Okay, which condition I can wait and watch, which condition I cannot wait and watch? No, Mihir. Fetal movement absent, that is IUFD. So in placenta previa, sir, we can wait and watch. Abruption, we should never wait and watch. Why? Anybody? Can you tell me? Can you tell me when does the bleeding of many students even after internship is over don't know this concept? Okay, when does the bleeding of abruption stop? Anybody? When does the bleeding of abruption stop? Okay, so please understand this. Abruption means that the placenta has detached. Placenta has, it's a premature separation of a normally implanted placenta. So here the bleeding will keep on happening, and the patient will die. Okay, no, not uterine rupture, no. Okay, yes, patient will come in shock, and abruption you cannot wait and watch. Please understand this, the abruption bleeding. Students tell me two things, sir. When there is no more blood left in the patient's body, then the abruption bleeding will stop. Yes, and very good, Varsha. The abruption bleeding will only stop once I deliver the baby, and then I deliver the placenta, and then the uterus will contract. So remember this, student, my dear student, that the bleeding in abruption stops only after the complete, only after delivery of both, delivery of the baby, and then of course delivery of the placenta. In short, yes, very good, Deepak, because it will keep on increasing. So abruption bleeding, the clap if you have learned something new. Okay, so abruption bleeding will only stop after baby delivery and after delivery of the placenta. So keep in mind, my dear student, that in abruption we are never going to wait and watch. एक rule छप लो, छाप दो दिमाग में, deliver ASAP. Deliver as soon as possible. Most of the time I need to go and do LSCS. Very rarely, if delivery is likely to happen, we can have a vaginal delivery also. Okay. So deliver as soon as possible. And therefore, one more point you need to keep in mind. Can anybody tell me we are continuing with the same apna placenta previa and our abruption? Can any, so we know painless bleeding, painful bleeding. I'm coming to etiology in some time. Can anybody tell me how is the mode of delivery? How is the mode of delivery? Anybody? Yes, very good, Jimit Patel. If abruption, you wait and watch Seedha Jail. Very good, love you. Yes, excellent. Okay. Yes, so please understand this. Baby placenta फाड़ के बाहर नहीं आ सकता है. फटा placenta निकला hero, not possible. You can see over here, this is the placenta, this is the baby. So baby cannot perforate through the placenta and come out. So please keep in mind and never ever induce the labor. Again, by inducing labor, you are causing more bleeding. So placenta previa, I will have to do LSCS. Okay. Okay, thank you, Karl. Yes. Okay, yes, but abruption not necessarily always. Okay, so keep in mind, my dear student, that placenta previa, the delivery is always by LSCS. Always, always, always. Okay, abruption, if it's a fetal, remember abruption ke saath, if it's a fetal distress, which is most of the time the case, yes, even abruption will require LSCS. But by chance, if the baby is dead, or in case if it's a very advanced labor means, sir, suppose the patient is 6, 7, 8, 9 centimeter dilated, very much advanced labor, then we can augment the labor by giving oxytocin and try. This is absolutely PG level. They're not going to ask you such question. We can try VD. VD is my short form for vaginal delivery. Okay, so if it's an advanced labor and if the fetal heart rate is normal, there is no fetal distress, then we can. So abruption mein VD, vaginal delivery possible. आप खाली लिखेंगे. But in no RSR, no forceps, no vacuum. Okay, RSR. Again, if you apply, how will you apply forceps or vacuum? Look over here. The placenta is in the lower segment. There's no space to apply forceps or vacuum. So no forceps, no vacuum. Okay, seedha jail, not possible. Okay. Forceps or vacuum also not possible in a patient of placenta previa. Is this understood to all of you? Yes. So these are the basic points in mind. And now let us begin our MCQ. Chalo, start in the chat box. Yes, biomed funkies. If the baby is dead, we will try vaginal delivery. But keep in mind, I need to augment the labor. Okay, augment the labor. Why? Because I want to deliver quickly. So yes, if the baby is dead, you are correct. We can try in abruption. Placenta previa, write down. Very good point. Placenta previa, it is LSCS. Even if the baby is dead, even if it is IUFD. Okay, is it clear why? Even if it is IUFD, why? Because, sir, baby cannot perforate to the placenta. Mother's life is at risk, isn't it? So in placenta previa, you can see that here the baby is, placenta is covering the whole os opening, isn't it? So even if unfortunately you are correct, even if the baby is IUFD, still I will have to do LSCS only. So it is always LSCS. If it's live baby, LSCS, even if the baby is IUFD, mode of delivery is always here. Yes, here in abruption, we can try a vaginal delivery. Is this understood to all of you? Yes. So now tell me, all of you. Yes. Okay. Yes. Okay. So now the first question for the day: risk factors for placenta previa are all except. ध्यान से question पढ़ोगे in the chat box. And many students don't read the question correctly. Okay. No. Okay, risk factors for placenta previa. So all of you, please pay attention. Risk factors for placenta previa are all except. Okay. So please understand this, please understand this. No, 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 it is not abruption. Okay, so all of you, what are risk factors for placenta previa? Risk factors, or when we say etiology for placenta previa, okay, or what are the predisposing factors? Okay, etiology, let me put it in that way. Okay, what all will contribute in the etiology? Okay, yes, very good. Abhi Anjali, Dr. Irresistible, Ashima, now the right answers have started coming. Please pay attention. Point number 1. Past history plays a role everywhere. एक बार जो हुआ, हिस्ट्री ऑलवेज रिपीट्स इट सेल्फ. सो एक बार अगर प्लासेंटा प्रीविया है, नेक्स्ट टाइम अगेन देयर इज प्लासेंटा प्रीविया. Okay, second thing what you need to keep in mind is that one of the very important risk factors for placenta previa, prematurity. Why? Because starting में many placentas are low lying. Starting में means what I mean is कि sir, when we are say 16, 18, 20 weeks. That's why this, I'm so happy. This was the PYQ. ये PYQ था कि sir at 18-20 weeks placenta is low lying. What do I do? Wait and watch and repeat the sonography at around 32-33 weeks. Most of the time by 32 weeks the placenta goes up, isn't it? So sir, as the uterus will keep on increasing in size, the placenta gradually moves upwards. So if at 16-20 weeks the placenta, it is placenta previa, we don't do anything, just wait and watch. Many times the placenta will go up. Is this crystal clear to all of you? So keep in mind this, my dear student, that prematurity is also the risk factor, and therefore previous LSES, very important, that scar on the uterus prevents the placenta from going upwards or migrating upwards. And yes, in multiple pregnancy or twins में placenta itself is bigger. Okay, twins में क्या होता है, all of you, sir, it is a very big placenta. Okay, big placenta itself is very big, so placenta will come because it's a big placenta, and then there are two babies. Okay, so placenta previa may be there is twins may likely because it's a it's a physically big placenta which can come in front of the cervix and cover the os. So you can remember, instead of multiple pregnancy or twins, what is going to happen? It is a placentomegaly. Placentomegaly matlab big placenta. Is this understood to all of you? The answer is preeclampsia. Very easy, because I told you in the very important, we discussed this before also, and those who are here for the first time, okay, when we look at the both the conditions, hypertension, okay, hypertension and preeclampsia are one of the most important risk factors for abruption. So if the BP is 150/100 and then we get then the patient starts bleeding, we have to think of abruption. Yes, finally, when there is lot of bleeding, patient will be in shock. When the patient is in shock, in both the cases, the BP will be less. Okay, so when the patient is in shock, patient can go in shock in previa also, abruption also. At that time, the blood pressure will decrease. But initially, there is a risk of high blood, there is a high blood pressure may contribute to abruption. Is this understood to all of you? So please keep this in mind. And the answer over here is preeclampsia. And lastly, also remember smoking or puff. Okay, smoking also contributes to both. So clap if you feel happy. Placenta previa, देखो ठोको ताली, PP. Placenta previa, everything is with P. Clap. Prematurity, P. Past history, P. Previous LSES, P. Placentomegaly, P. And puff is smoking also P, told to you by Dr. P. Dr. P matlab the OGGuru, Dr. Puneet Bhojani. I am here with a single agenda to make OBGY your most favorite subject and most scoring subject. लेकिन ये P नहीं है, याद रखना ये preeclampsia नहीं है, and that's the trick thing, because hypertension, preeclampsia or hypertension does not contribute Very good. PPPP. OG in the chat box. Okay. Now tell me, chalo. Now risk factor for abruption are all except. Now you should know very easy. Okay. Chalo. Risk factors or etiology. Come on, come on, come on. नो 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 नाम यर अरे बच्चा लोग आप क्यों मिस्टेक कर रहे हैं यस हियर इट इज प्रीवियस LSCS previous LSCS has no connection to abruption past history definitely plays a very important role and preeclampsia so for abruption I need to keep in mind the two most important piece all of you for abruption keep in mind one is preeclampsia and hypertension one is preeclampsia and hypertension and second is your past history very good all of you so keep in mind the most important risk factors are preeclampsia and smoking of course is a risk factor in past history previous LSCS is the answer over here previous yes except yes very good Mr. Unknown so that is what I'm telling you कि student make a mistake and they don't read the word except so ये simple question है कोई googly नहीं है remember previous LSCS keep in mind previous LSCS is a risk factor for placenta previa and not for abruption thumbs up in the chat box okay trauma yes trauma is for abruption correct very good trauma mein yes if there's external trauma and even sudden decompression if it's polyhydramnios and suddenly all the liquor gushes out sudden decompression and yes as you rightly said even trauma may contribute to abruption yes I agree with you but not previous LSCS यस वर्जिन एमसीक्यू था बेटा वर्जिन एमसीक्यू अपना इसके लिए था यूट्यूब चैनल के लिए वर्जिन एमसीक्यू था हमारा ऐप में तो ऑलरेडी ये सब एमसीक्यूज ऑफ कोर्स हमने कवर किया है ओके सो इट्स क्विकली अंडरस्टूड टू ऑल ऑफ यू यस सो डू शेयर दिस वीडियो विद ऑल योर फ्रेंड्स एंड कलीग्स एंड डेफिनेटली सब्सक्राइब टू माय यूट्यूब चैनल ऑल्सो एंड स्टार्ट फॉलोइंग मी ऑन इंस्टा एंड on Telegram also chalo now very simple based on whatever theory I have told you till now can anybody tell me what is the diagnosis for this MCQ chalo clinical case based scenario what is the diagnosis yes very good yes okay very good the thing is that painless bleeding in the question paper and head floating uterus relaxed because placenta prevents the head from coming down this is placenta previa nothing to think and also blood pressure is normal see as I told you same question if I have a patient who is hypertensive okay if I have a patient of preeclampsia or hypertension BP given to me 150 100 and comes with painful bleeding Now what is our diagnosis? Can anybody tell me? If I say that patient is a known case of hypertension, blood pressure is high, and there is painful bleeding, then what do I call it? Then what will be the diagnosis? Yes, then sir, we will mark it as abruption, because sir, high blood pressure preeclampsia is one of the most important risk factor in painful bleeding, and even the uterine tone is going to be increased. Excellent, all of you, excellent. Chalo, now tell me the diagnosis, and tell me the uh, management. Okay. 33 weeks pregnant lady, bleeding, hemoglobin okay, BP okay, uterus relaxed, head floating, fetal heart sounds, the fetal heart 140. Somebody also asked about the normal fetal heart rate. Yes. What, and anybody, one more MCQ. Chalo. What is the normal fetal heart rate? Varsha, induction of labor, jail. Okay, induction of labor nahi. Diagnosis, very good, sir. This is again our placenta previa. And sir, in placenta previa, why? Why placenta previa? Sir, painless bleeding, first clue. BP normal, second clue. Uterus relaxed, head floating. Now this is placenta previa. In placenta previa, those who will do induction of labor and forceps delivery, jail. Why? Because sir, when I induce labor, I told you, in placenta previa, if I induce the labor, in placenta previa, the bleeding is going to increase. Okay, yes, normal fetal heart rate, we are coming to that. Very good. Normal fetal heart rate is 110 to 160. 110 to 160 is normal. Anything less than 110, fetal bradycardia or distress. More than 160, fetal tachycardia. Okay. Okay. Yes. No, beta Varsha. Even induction of labor should not be done. Even at 37 weeks. Never. Whether it is. Okay. So now tell me this in this question. Very good, all of you. In this question, we have placenta previa. Now, what about the mother? Yes, sir. Mother is stable. And yes, very good, Mihir. We are only 33 weeks. I'll teach you three variations with this MCQ. We are only 33 weeks. So I will wait and watch. And what will I do in wait and watch? And why we wait and watch? Sir, in placenta previa, when we wait and watch, what do? You admit the patient, give her steroids, so that lung maturity फटाफट हो जाएगा, and closely observe the patient. What is this called as? Anybody? Chalo, same thing ka one more MCQ. Which is called as expected management or wait and watch in placenta previa? What do we call it? Yes, so this is called as the McAfee and Johnson regimen. McAfee and Johnson regimen. Okay, yes, but now one more point in this, because yeah, of course I'm coming to the answer of the previous MCQ. Now when I want to wait and watch, there are three conditions which have to be satisfied. What are the three conditions to wait and watch? Okay, so when I want to do the MJ, Michael Jackson or McAfee Johnson, wait and watch, point number one, of course the mother should be stable. Is this understood to all of you? So look at the question paper. Mother is stable. Beta, Vaza Previa, Yogesh Punya, Vaza Previa, absolute PG level. Within minutes, the baby will die. Vaza Previa, remember, my dear student, exclusively fetal blood loss. Within minutes, the baby will die. Okay, so bleeding start, fresh bleeding, baby dead. That is Vaza Previa. Okay, second, very good. There should be no fetal distress. That means the baby should be stable. So mother stable, no fetal distress. And third thing, pregnancy is less than 37 weeks. Then only wait and watch. We should get 3 out of 3. All the three conditions should be satisfied, and therefore all of you look on the board, sir. Here we are 33 weeks. Okay, here the mother is stable because BP 120/70 hemoglobin, and fetal heart rate is also 140 normal, and therefore wait and watch is the answer. Is this understood to all of you? Now all of you see the variation in the question paper. अभी ध्यान से मुझे बताओ कि इफ आई मेक दिस फीटल हार्ट रेट 140 के बदले आई मेक इट 80 पर मिनट. नाउ व्हाट इज द आंसर? Now what is the answer? 80 or 70 to 80 per minute. Now what is the answer? Clap if you feel happy. So sir, now this heart rate of 80 to 70 indicates. So with one MCQ, I am teaching you 4 MCQs. With one MCQ, very good, Jimit Patel. Okay, sir, now emergency. Immediately we will do LSCS. Again, induction तो है ही नहीं, forceps है ही नहीं, and now if I wait and watch, the baby will die. This fetal distress will lead to IUFD. It's like 80, 70, 60, 40, 30, 20, baby dead. So now don't wait and watch. Clap, 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 thoko tali. And last important point, all of you, last important point, also keep in mind that instead of this 33 weeks, if I make the patient as 37 to 38 weeks, now what is the answer? Thank you, Mihir. Thank you. Yes. Beta, you will fall in love with OBGY and it will be your maximum marks is my guarantee. Yes. And definitely if you haven't subscribed to the OGGuru app, please subscribe it and within one day you will revise the entire OBGY. Yes. Sir, now once we are 37 to 38 weeks, again there is no point waiting further and I will do LSCS only. Very good. So remember my dear student, placenta previa, the delivery, because sir now there is 37 weeks. Now there is no point in waiting further. Now, why do you want to wait? You are waiting for what? Because suddenly labor will start. Labor will cause bleeding. So even before the bleeding starts, once you reach 37 weeks, there is no point waiting further. Okay, so please understand this, that when we are waiting and watching, when we wait and watch, we are only waiting for the baby ka lung maturity, and the concept is you wait only till 37 weeks, and once 37 weeks are reached, we will go and do LSCS. Okay, so I wait till 37 weeks provided if the mother and baby are stable. Is this understood to all of you? So I come back to the original question. 33 weeks hai, diagnosis is placenta previa, and the answer is wait and watch. There is no question of induction, there is no question of forceps, and cesarean section not required now because of here the fetal heart rate is normal and mother is stable. Is this understood to all of you? Yes. So delivery is by LSCS. You wait till 37 weeks only and then do LSCS. But you wait, of course, if mother and baby are still. Chalo, now tell me, aage, one more MCQ. What is this option number 2? Brand-Andrews method. What is this Brand-Andrews method or Brand-Andrews maneuver? Brand-Andrews method or Brand-Andrews maneuver. Chalo, और एक virgin MCQ. Sir, it is control cord traction to deliver the placenta. Okay, it is, sir, one hand is not for the, okay, one hand, one artery forceps and ऐसा cord घुमाते घुमाते control cord traction, and one hand on the fundus and you give control cord traction to deliver the placenta. That is called as Brand-Andrews method. Okay, OG in the chat box if you are loving it. Yes, third stage of labor. And Creed's method is again an outdated method to deliver the placenta. We don't use it. And anybody Very, very important. Well, there's no Lily's method, there's a Lily's chart. Chalo, mere student, Lily's chart, where do I use it? Lily's chart is used where? Lily's chart is used in RH iso immunization when we go and do amniocentesis. Okay, when we go and do amniocentesis in a case of RH iso immunization, there is a Lily's chart. Okay, very good, Priyadarshani. So moving on to the next very, very important topic, and that is infertility, PCOS, hysterolaparoscopy. Again, on this is a second favorite hot topic. So stay right till the very end. I'm going to discuss also oncology. So lots of students were telling me, okay, sir, आप cancer please सिखाइए. So the last topic, stay right till the very end. I'm going to discuss the cancer also. So the first topic we discussed APH. This is not second, third, fourth. This is a very big topic because here on this also questions are coming. Okay, is this understood to all of you? So now infertility ke liye the important point, and before that when we go to PCOS, infertility definitely I'm discussing. Anybody, what criteria are used for diagnosis of PCOS? Anybody? In PCOS, for diagnosis of PCOS, which criteria we use? Yes, very good. Only the students who attend my lecture or read my books will get this correct. And can anybody tell me these are the Rotterdam criteria way back in 2000? Excellent, all of you. Rotterdam criteria of 2003. There are totally three criterias. Okay, criteria number one, an ovulation. The lady is not ovulating, there is an ovulation or oligo-ovulation, matlab infrequent ovulation. Second one is hyperandrogenism. Hyperandrogenism, which could be biochemical or clinical. Biochemical means, sir, either the testosterone is elevated, and clinical means when I look at the patient, acne, oily skin, hirsutism. So I'm liking A and H. Okay. And third is the ultrasonography criteria. Now, can anybody tell me कि ultrasonography में what we see? Ultrasonography में, in the normal sonography, yes, I'm also going to show you the picture, image based question. What is this pattern called as? Yes, on ultrasonography, very good. The necklace pattern, and I will hold on with this necklace of pearl pattern, and we count the follicles and what are the size of the follicle. And if I tell you, yes, yes, okay, yes, 12 or more than 12 or more, necklace of pearl pattern, excellent, all of you. And what are the, very good. Okay, so these are all immature follicles. Immature follicles which are between the size of 2 to 9 millimeters. Okay, 2 to 9 millimeters. Now, can anybody tell me, virgin MCQ, what is the size of the mature follicle? Yeah, latest criteria is more than 20. In the old, even more than 12. Okay, 12 or more than 12 is also correct. With a normal low power machine, we count 12 follicle. New higher machine, 20 follicles. Okay, excellent. I want to know the size of the normal follicle. Normal. And therefore clap if you feel happy. How many of you feel PCOS का फुल आज एक बड़ा सा खुलासा कॉन्सेप्ट ब्रेकिंग न्यूज. PCOS फुल फॉर्म क्या है? Polycystic ovarian syndrome, PCOS. I am telling you, there are no cysts in the ovary. How many feel PCOS matlab, how many feel के multiple cyst in the ovary? How many of you feel के multiple cyst in the ovary? Is it true or is it false? Very good, Biomed Funkies. Very good, Archana Roy. Yes. So please understand this, that multiple cyst in the ovary, this is false. It is a complete misnomer. Very good, Biomed Funkies. There are no cyst. अरे सर क्या सिखाया? There are no cyst in the ovary. Nobody will teach you like this, is my guarantee. Okay, is this understood to all of you? Okay, is this understood to all of you? So please understand this, that yes, very good. Okay, there are no cysts. Okay, okay. So the thing is that why these are what? So these are all immature follicles. These are all immature follicles. So the technically correct name, they will not, but it should be polyfollicular. Okay, there are multiple small follicles within the ovary. Okay, and write down, okay sir, there is no cyst in the ovary. And one more MCQ which I wanted to ask you was that, sir, the size of the mature follicle, the size of the mature follicle is 18 to 20 millimeter. What is this mature follicle also called as? What is this mature follicle also called as? Yes beta, मैं इसलिए मैं हूं ना. The mature follicle is also called as Graafian follicle. Graafian follicle. So basically follicle को, yeah, dominant follicle, very good. Dominant follicle or Graafian follicle. So follicles have to reach a size of 18 to 20 millimeter. Then there is ovulation. In PCOS, all the follicles are immature and they are in the size of 2 to 9 millimeters only. Okay. So now can anybody tell me this MCQ on USG? Chalo, identify the image based question. What is this image? What is this image? So रोटेटम राइटर याद रखेंगे. रूपल कुमावत, सब बी डांडी गुल, क्लीन बोल्ड, गुगली. Yes, all of you gone. 2 to 9 centimeter होगा क्या? Clean bold. Yes, this is my diagnosis of PCOS. This is the typical necklace pattern, and in necklace pattern, okay. So now, yes. So see, this is how you make a mistake. ये जिंदगी भर मुझे याद रखोगे बेटा, ये mistake करोगे कि it is not 2 to, student 2 to 9 पढ़ के मार्क कर दिया. 2 to 9 सेंटीमीटर, 9 सेंटीमीटर मतलब बड़ा सा सिस्ट है. Yes, yes. PCOS में होता है 18 to 20 सेंटीमीटर. Oh my God. 18 to 20 millimeter तो normal, the normal or the mature follicle. Okay, the mature follicle, mature follicle also we call it a dominant follicle, जो हमने अभी बताया Graafian follicle. Yes, sir, 2 to 9 millimeters होगा. So all the follicles will measure between 5. Again, ये virgin था, ये scam हो गया. जो बोले थे ना सर कि teacher new MCQs बताओ सर, new MCQs on YouTube. Okay, so new MCQ on YouTube. Okay. Is it clear to all of you? Yes. So this is the typical necklace of pearl pattern. And if you see all this 1, 2, 3, 4, 5, 6, 7, 8, all these are chote follicles which will measure between 2 to 9 millimeters. So I have to choose as 5 to 6 millimeter. Yes, 5 to 6. Okay, not 2 to 9 centimeters. So exam में ध्यान से पढ़ना है. Superb. Thank you, Ankit. Thank you. Yes, yes. Thank you. Superb. You will not fear it. It will become your most favorite subject. Still, abhi bhi time hai. All those who haven't yet subscribed to the app, quickly get in touch with me on WhatsApp. I give you guarantee just 1 day dedicate and your entire 30 में से 30 maximum marks you can get in OBGY. It's a very scoring subject. Okay. Yes. Okay. Now see this. What is this? Again a PYQ. This is again a PYQ. We have got a patient with infertility treatment with some ovulation induction agent. And what is this complication? Why I have kept both pictures side by side. Both pictures side by side so that there is no confusion among the students. Yes. Okay, sir, please don't make a mistake. This is not PCOS. PCOS, I just now showed you. In PCOS, there are multiple small follicles. Here, sir, and can anybody tell me which ovulation induction agents? So, specifically when HMG or recombinant FSH is given, all the follicles start growing and the final risk factor is HCG injection. HCG is the main culprit. When I give HCG as a final trigger, very good, Sunshine, Anuj, all of you correct. So this is OHSS because here the follicles are big, 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 big. This follicle will be like 18 to 20 millimeter. Okay, so they are big follicles also coming in the center also. And one more important point which you need to keep in mind, that along with this there is always ascites, free fluid. There will be lot of ascites which will be there. Okay, ascites will be there. So big follicle, when you get a picture like this, okay sir, there are all big, 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 big follicles, then please mark it as OHSS. And specifically this history will be given to you. Yes, very good, Ajay. Yes, yes, ascites present. Very good. Yes, from the urine of the postman. Yes, H Sunshine, absolutely correct. HCT, hematocrit will increase. Why? Because of hemo concentration. So this ascites, don't forget, ascites is a part, and when HCG is the main culprit. Okay. Very good. Yes. So this is your OHSS and not PCOS. Okay. Is it crystal clear to all of you? Very, very simple. We go to the basics of MCQ and the definition of infertility. Again, likely. Yes. History of IVF also. Yes. No, there's no number. We are coming to this as a doctor. Very good. As a treatment of infertility, the treatment of this. Yes. So now, 25-year-old lady is brought to the OPD by mother-in-law. Generally, mother-in-law, yeah, anybody, husband, father, anybody can bring. What do I do? Okay, yes. Please, and directly student पढ़ता है HSG कर लेंगे, ये कर लेंगे. No, please understand this. They are married only till 6 months. The infertility, to classify the patient as infertility, the definition is not able to conceive in spite of 1 year of regular unprotected intercourse. Okay, now please again keep this in mind. Not for marriage since 1 year. If the husband is in India, wife is in America, then that is not infertility. So they are not able to conceive after. How many of you feel infertility is not able to conceive after 1 year of marriage? Correct? Definition. 1 year of marriage. Chalo, true or false in the chat box. Why? Because I jokingly tell all my students कि वो खाली एकता कपूर के सीरियल में होता है और हिंदी पिक्चर में होता है कि हीरो हीरोइन मीट एंड फर्स्ट शॉट इटसेल्फ द हीरोइन प्रेग्नेंट. ओके, तो यस, प्लीज अंडरस्टैंड दिस. वेरी गुड. दिस इज फॉल्स बिकॉज मैरिज सिंस इज नॉट इम्पॉर्टेंट. मतलब मैरिज इज इम्पॉर्टेंट, लेकिन इफ they are staying separately, or husband is using protection. So 1 year of regular unprotected intercourse is considered infertility. Since this is only 6 months, we are going to just tell the patient reassurance or wait and watch. Tell the patient, okay, just relax, go home, because if you start investigating, the stress goes up, and stress, the further success goes down. So patient को खाली बोलना है कि relax हो जाओ, go home, yoga, meditate, yoga से होगा, yoga से होगा. Okay, tell them home के go back home, enjoy. After 6 more months you come back to me. Okay, is this clear, crystal clear to all of you? So please keep in mind reassurance. But one more thing, can you tell me what, as a good doctor or a good obstetrician, what it's a very good time, one medicine I can start for the patient, one medicine or one supplement which I can start for the patient at this stage. They are planning pregnancy. Yes. Anybody? What one? Okay, now come back. पढ़ाई पे आ जाओ. ज़्यादा सोचना बंद करो. Yes, very good, excellent, all of you. Okay, sir, please start her on folic acid supplementation, because all of us know it is periconceptional folic acid. So which month, when will she conceive, we do not know. So it's always best, okay, let us start her on folic acid. Start the folic acid supplementation at this stage only. Is it understood to all of you? चलो now again a virgin MCQ. ये क्या picture है और ये क्या दिखाया है आपको as a important investigation for infertility? Okay, so this is a X-ray, and this is a hysterosalpingography. This itself is an MCQ, and if you see कि sir ये जो HSG में क्या होता है, sir, we get a triangle uterine cavity, and then the dye will enter the fallopian tube, and then if the dye gets come out over here, this is called as the spill of the dye. Many students feel spill is not, no, spill is normal, spill hona chahiye. So now if all of you go, and if you, of course, is very clear to all of you, but थोड़ा सा अगर zoom करके देखेंगे, तो कैन ऑल ऑफ यू टेल मी कि ये जो वाला पार्ट है, सेंटर इज व्हाट? सर, दिस इज द ट्रायंगल यूट्रस. कैन इजीली एवरीबडी सी दिस? ये है फेलोपियन ट्यूब, एंड okay, so sir, this is one fallopian tube. All the way, this is another fallopian tube, and इतना भर भर के इतना सारा spill है. Those who are saying bilateral cornual block is wrong. Okay, bilateral cornual block जिसने भी कहा वो wrong है. Sir, this is a absolutely normal HSG. Absolutely, yes, bilateral spill is present. Very good, all of you. This is normal. Okay, bilateral femoral block नहीं, because there is a spill present. So this is a normal. I'll just show you. Yes, okay. Bilateral cornual block में क्या होगा sir? Only the uterus is seen. Only the uterus is seen, and the tube is not seen only. Okay. Okay, the tube will not be seen. Then we can call it as bilateral cornual block or it could also be a spasm. Is this understood to all of you? हाँ बेटा फास्ट ही करना पड़ेगा. यस, ऑप्शन सी बाइलैटरल फिम्ब्रियल ब्लॉक. उसमें कैसे दिखेगा आपको? सो आई एम एक्सप्लेनिंग यू ऑल. ओके, इन द बाइलैटरल फिम्ब्रियल ब्लॉक, सर द यूट्रस विल बी सीन, the dye will go all the way till the fimbrial end, but then there will be no spill. And because generally it's a fimbrial block, the tube will get distended and this will look like this. So you will not see any spill coming out. Okay, so here you can clearly see that there is so much spill. Can you see this spill over here? All this what is there is the spill of the dye. Okay, so this is the uterus, this is the fallopian tube, and this is all this what you are seeing. All this what you are seeing is the spill of the dye. So this is absolutely a normal HSG. Okay, virgin MCQ will come in the difficult paper for sure. Yes, very good. Very good. Okay, sir, in bilateral fimbrial block, there will be no spill, and also it could be a hydrosalpinx. Tubes are blocked. Okay, and in Asherman syndrome, you will get multiple filling defects. So absolute, the highest level of gynecology which anybody can teach you is this. Okay. Is it clear? So you get multiple filling defects in Asherman syndrome. Okay. Now, can anybody tell me what is the best investigation to check the tubes? There is an X-ray. Best investigation to check the fallopian tubes. And that is what investigation? Yes. The best investigation for tubal patency is when I do a laparoscopy, and in the laparoscopy we go and put a dye. What dye is used in laparoscopy? Anybody? Laparoscopy mein we put a methylene blue dye. Okay, we put a methylene blue dye, and that will see, we will see the dye coming out from the fimbrial end. So this is a laparoscopy view, and yes, okay. Yes, okay, very good. So you can see that the blue color dye will come here, and everybody start jumping in the OT. Blue hai pani, pani, pani. Yes, very good. Methylene blue is the dye, and that clap if you feel happy. This is the answer. Can anybody see where I'm coming? Yes. Okay, seeing is yes, very good, excellent, all of you. So, sir, in this picture, this is like the MCQs Miss will see. Okay, so here what we see, sir, this is the uterus. Okay, and also explain to you quickly between uterus, this is the ovary. So this is the terrace view. Yes, please understand this. And this blue color dye is coming out is a methylene blue dye. That is not a hysteroscopy. Yes, this is not a laparoscopy. It is laparoscopy chromoperturbation done with a methylene blue dye. Virgin MCQ. Virgin MCQ. Virgin MCQ. Okay, so okay, so please keep in mind, so this is the laparoscopy view. Okay, now very good, very good. Okay, so this is the best investigation. It is the best investigation for tubal patency. Okay, keep this in mind. Now, can anybody tell me this? Okay, these two MCQs. Now, to show you the difference between the this and this. Okay, so can anybody tell me, patient comes with infertility with midline septum in the uterus, so septate uterus, which is the best management for this condition? Again, a PYQ. Yes, beta. Hunter, the dye will collect in the pouch of Douglas. That means the dye will come out of the fimbrial end. That is the purpose. Okay. Then you can remove the dye. You will remove the dye. That is what it is. You are correct. Okay. All this dye which will come out, and yes, it will fall in the pouch of Douglas. Okay. So now all of you pay attention. What is this MCQ and what we are going to, how we are going to manage this. Okay. Yes. Very good. So now all of you please pay attention. The important point is that in laparoscopy, we put in a telescope through the patient's abdominal wall, and we will see everything from outside. Like just now what I showed you, you will see the uterus, you will see the fallopian tube. Okay, you can see, and all this is laparoscopy view. Okay, like, and this is the ovary. So this is the terrace view. Very good. Terrace view means, sir, if you go on the terrace of the building, you will see the road and the car from outside. But here, can you see what is inside the uterus? No. If all of us are in one classroom, I am seeing all of you. That is the hysteroscopy view, to see the telescope. So when I put in a telescope through the patient's cervix inside the uterus to see the cavity, that is the hysteroscopy. And the important point over here to be kept in mind, my dear student, is that the septum in the uterus, matlab septate uterus, one of the most common. Okay, septate uterus is like this. Here is the septum is projecting inside the cavity. So there is no point doing laparoscopy. Laparoscopy say you cannot see. All of you look on the board, this picture. Now here you are seeing the uterus. Now can you tell me inside the uterus whether there is septum or not? No sir, we cannot say. So here sir, I have to go through the hysteroscopy route, and with the scissors I have to cut the septum. I have to keep on cutting the septum. That is, you can see like this, like this, like this, like this. You keep on cutting the septum like this, like this, like this. So the trick over here is, okay, for septate uterus you require a hysteroscopy. Yes, medico, and same thing also. So this is not hysteroscopic adhesiolysis. It is called as hysteroscopy septoplasty or hysteroscopic septal resection. Is this understood to all of you? Beta, laparotomy beta is when I open up the whole abdomen. Laparotomy is opening up the whole abdomen. Basic concepts. Okay. Laparotomy is I open up the whole abdomen. Laparoscopy is I put a telescope. Okay. Is it understood to all of you? Okay, laparoscope is a telescope which you put in the abdominal wall. Okay, so laparotomy is opening. Okay, and yes, similarly somebody asked me, okay, if it is a bicornuate uterus, two separate horns, then on laparoscopy we can differentiate the two separate horns. That's a bicornuate uterus. Okay, so bicornuate uterus mein upar se pata chalega this. Okay, is it clear to all of you? Yes. So this is about the cavity. And can anybody tell me this one more? Hysteroscopy is indicated in all of the following except. Yes, it's an acute angle in a septate uterus because septum is very close by. Bicornuate, two separate wide angles. So HSG will see very wide. Okay, but confirmatory is hysterolaparoscopy. Yes. So now all of you pay attention. Asherman syndrome is what? Intrauterine adhesions. So yes, sir, in intrauterine adhesions, the hysteroscopy has a role. Anything to do with the cavity. Very good. Please understand this. Hysteroscopy is for the cavity inside the classroom view. Again, except hai. Of course, sir, the patients if has got a polyp or if there is a submucosal fibroid all that is going to cause menorrhagia and septate uterus. All this can cause even infertility. So sir, for menorrhagia, we will detect a polyp or a fibroid in the cavity, and all these things will also cause infertility. The answer is adenomyosis. Adenomyosis requires ultrasonography. What is adenomyosis? Yes, because it is the glands, the presence of glands. What is adenomyosis, all of you? Sir, adenomyosis is the presence of glands within the myometrium. You will see cystic spaces. You will see glands within the myometrium. The cavity is normal. The cavity is normal in adenomyosis. So hysteroscopy, no role. No role for hysteroscopy. Is this understood to all of you? Yes, yes, it is the presence of endometrium within the myometrium. So you do a ultrasonography for adenomyosis. Is this understood to all of you? Yes. So this is, and remember this is laparoscopic chromoperturbation with a methylene blue dye, and that is your best investigation. Very, very important trisomy 21 topic. इस पे surely question आता है. Moving on to third topic. Okay, so now can anybody tell me, for trisomy 21 detection, I have got certain screening test. Can anybody name the screening test? And I have got a confirmatory testing. When are the confirmatory test? What are the confirmatory test? And what is the screen? Yes, Down syndrome. Now, can anybody tell me how is the dual marker test done? Yes. How this, many students do not know this even after the exam is over. Anybody? Dual marker test or a triple marker test? What is the sample? How is the test done? Yes. How is the test done? Yes, yes, yes. We are going to discuss that. How is the dual marker, triple marker test done? Very good, all of you. So do you know how is the test done? Yes, yes, all of you are telling me, but how is the test done? कैसे करते हैं? Is it fetal blood, CVS, amnio, maternal blood? Yes, but what is the sample? Yes, so screening can happen with ultrasonography. Very good. That is the NT scan. Very good. Done towards the end of the first trimester. No, see Ritesh, this is the trick. All over India, even it's a sad thing that final year over, internship over, PG or entering into NEET PG also, students do not know. Whenever I ask anybody that how will I do a dual marker, triple marker or a quadruple marker test, the first answer I get is amnio or CVS. Wrong. Amnio, CVS are your confirmatory testing. Yes, very good. The screening, it's a simple blood test. It's a blood test. Very good. Maternal serum. Maternal serum is taken, and on the serum I can do dual marker, triple marker, quadruple marker test. Clap if you have learned something new. So sir, it's a simple blood test. Now, and the confirmatory test, very good, in the whole world, the confirmatory test is karyotyping. Karyotyping, I can get the sample by doing a chorionic villus sampling, or I can do amniocentesis. Now again, can you tell me, when do we do which? When do we do which test? Okay, so chorionic villus sampling is done in the first trimester, and amniocentesis, if required, is done in the second trimester. Very good. Okay, is this understood to all of you? Yes, and out of this test, which is excellent all of. Okay, so chorionic sampling first trimester, amnio second trimester, and triple, and yes, very good. Okay, not 18 month beta, amnio 18 weeks. Okay, yes. So now can anybody tell me, I'm coming to this in a minute. Yes, chalo. All of the following are screening tests in the second trimester for aneuploidy or trisomy 21 except. Okay, so can anybody tell me with the answer? Yes. So all of you pay attention. Okay, sir, when I do a dual marker test, it is HCG and PAP-A, PAPPA. HCG is higher than normal, PAP-A will be lesser than normal. Okay, and dual marker test is done in the first trimester, 11 to 13 weeks, towards the end of the first trimester. And can anybody tell me last year PYQ, triple marker test, quadruple marker test are done when? 16 to 18 weeks of gestation. Is this understood to all of you? Okay, 16 to 18 weeks. Okay, and in triple marker test, very good, HCG, yes, very good, HCG, alpha fetoprotein unconjugated estriol, E3 कैसे याद रखना है, यहाँ पे 3, यहाँ पे 3 है, and that's why triple marker, HCG higher, other two lower. And when we add the quadruple marker में inhibin A, that becomes the quad test. So here the question is, yes sir, HCG, alpha fetoprotein inhibin, the answer is PAP A, because PAP A, sir, is a part of dual marker done in the first trimester. HCG is also done in the first trimester, but HCG alpha fetoprotein is a part of your double and triple, so HCG can be done in second trimester also. Yes, okay, inhibin is higher than normal. Okay, now next, chalo, absolutely. Now if you've done this, you know the previous MCQ, you know this. All of the following are, which of the following is not true? Yes, sir, alpha fetoprotein is lesser than normal. Yes, we just now showed you. Sir, alpha fetoprotein will be lesser than normal. Okay. Then similarly, all of you know, even NT is going to be higher. Anybody? NT is what? Nuchal translucency up to 3 millimeter. It's a ultrasonography, and PAP-A is going to be lesser. Very good. The answer is HCG. You can see whether HCG is in the dual marker or triple marker. I showed you HCG is higher than normal. PAP-A is lesser than normal. Okay, HCG is arrow up. HCG is arrow up. Okay. Yes, NT scan is also. So the answer over here is our option number C. HCG will not be lesser, it will be higher. Okay, and NT ka, yes, up to 3 millimeter. Yes, very good. 3 to 3.5, somebody say. 3.5 is considered normal, it's in millimeters. Okay, NT scan again done between 11 to 13 weeks. Now, tough MCQ, virgin MCQ. What is this MCQ? 37 years old lady, gravida 2 para 1 living 1, 16 weeks pregnant lady with a past history of Down syndrome should be best evaluated by. Yeah, HCG is high. Very good. Yes, Jimmy. Wrong, wrong, wrong. Yes. Now please understand this, the importance of this MCQ. It's a very, very important virgin MCQ surely coming in the future exam is, okay, sir, she is a high risk patient. This one baby who is already living, she has a past history of Down syndrome. So please understand this, any screening test, any screening test result is like low risk or high risk. That's it. Screening test result is low risk or high risk, and that's it. It cannot tell you further. So please understand this, that sir, suppose if this patient, I do triple marker test and it is normal, can I confirm tell the patient that don't worry, relax, your baby is normal? No. And if it's abnormal, then confirm, can I tell the patient that your baby is 100% having Down syndrome? No. So sir, triple marker test and quadruple marker test have got no role over here, because they are only the screening test. Here when the patient has a past history of Down syndrome, I need to tell confirm. She will tell you, doctor, confirm मुझे बताओ, confirm tell me whether my baby is normal or again having Down syndrome, and the confirmatory testing is karyotyping, and you will next see the weeks of gestation, 16 weeks, and therefore amniocentesis thokotali is the answer. And if even one word, that is how see obs gynae, कि एक word भी change हो गया, OG in the chat box. Now tell me, suppose my dear student, I make this 16 weeks into, I make it into 12 weeks. Now what is the answer? I make it 11 to 12 weeks pregnant lady. Now what's the answer? But I'm not sure because I'm on the Puri Jagannath. I'm not sure whether this video will remain live. Hopefully this should keep live till the exam. Otherwise you can go to my YouTube channel also, and best is just subscribe to my app. 1.5 day, 570 rupees. You will revise the entire OBGY. Nothing more required. Very good. So now if it is 11 to 12 weeks, the answer becomes chorionic villus sampling, because it is also the confirmatory testing. Is this understood to all of you? Okay. So here, sir, I need to go for the confirmatory testing, which is, I come back to the original MCQ, 16 weeks hai, to chorionic villus sampling. If it is 11 to 13 weeks, then you mark chorionic villus sampling as the answer, and double marker, triple marker, they have got no role over here. Okay, is this understood to all of you? And this is your picture of what? Yes, so this is, you can see, we are putting in a we are putting in a sonography. A needle is put in the amniotic chamber and the amniotic fluid is sucked out. So this is a amniocentesis which can be done between 15 to 18 as the answer over here. This is the best option over here. Okay, yes. So this is a ultrasonography guided picture where we are putting in the needle in the amniotic fluid. It is not the chorionic villus, okay, under ultrasonography guidance. So it is 15 to 18 weeks. Okay, so moving on to the next important topic of primary amenorrhea. Again, a short questions are coming on this topic for sure, and this MCQ is very, very important because we have to tell you the new definition. What is the new definition of primary amenorrhea? And that is for any trisomy, okay? CRI, Criveri, any is okay, because it will tell you karyotyping, okay? So amnio and CVS, when I do amnio, it will tell you whole karyotype, okay? So it is for any, let it be trisomy 18, 21, all that, okay? Yes. Now please keep in mind very good that many of you should know What is the new definition of primary amenorrhea? So the old definition was 14 years and 16 years. That means there is no menarche. Patient has not yet got her menses, but 14 years of age if secondary sexual characters, because we remember the sequence: thelarche, pubarche, menarche. So breast development, axillary pubic hair, menses. This is called as secondary sexual characters. So if I see a girl in the OPD and there is no secondary sexual characters, okay, SSC, then even at 14 years, but if secondary sexual characters are present, that means, sir, if axillary hair is present, breast development, pubic hair is present, then I will wait. And if till 16 years also there is no menses, then I call it as primary amenorrhea. But my dear student, this is the old criteria. The new criteria has made one year lesser. This 14 has become 13 and this 16 has now become 15 years of age. So 13 years and in absence and 15 years in presence. Okay, is this understood to all of you? So surely this question is coming. So 14 question में नहीं देखना है. 13-year-old, no menses but with breast development. So this, sir, we will wait. This, sir, we will wait. And very good, all those who said, sir, 13-year-old, no menses, without breast development. C is the answer. Okay, C is the answer. Thumbs up if all of you have understood this. 14-year-old, no menses, without breast development is the old answer. Old answer. Okay, old answer. Okay. 14-year-old, no menses with breast development. Here also we can wait because she has got breast development. So I would like to wait here till 15. Is this understood to all of you? So please keep this in mind. Okay. So I hope all of you are getting it correct. Now can anybody tell me, when I look at primary amenorrhea, what is the most common cause? What is the first most common cause, second most common cause, third most common cause? So primary amenorrhea, the most common cause is Turner's syndrome or ovarian dysgenesis. It's the first most common cause. Okay, most common. RMKH, or also called as Mullerian agenesis, is the second most common cause. No, but pregnancy is the most common cause of secondary amenorrhea. Okay, yes, very good, Mihir. And third is your androgen insensitivity, also called as testicular feminization syndrome. Okay, so again 3 MCQs discussed. Again 3 MCQs discussed. Okay, now this is the answer. Chalo, yes, the commonest cause of primary amenorrhea is, all of you should get it correct. So the answer is okay. So I hope all of you have got it correct. Now, very simple. This is again short MCQ, PYQ. Yes. Okay. Now when I have a patient, please keep in mind, when I have a patient of primary amenorrhea with absent uterus, primary amenorrhea with absent uterus, please understand this, in the whole of OBGY only 2 options are there. don't have only two conditions. Primary amenorrhea, absent uterus, only two conditions in whole of OBGY. Sir, either it is RMKH or it is complete androgen insensitivity syndrome. Is this understood to all of you? So keep that trick in mind, and therefore whenever you have got, sir, primary amenorrhea, absent uterus, don't even think at option 3, option 4, don't even see them. देखो ही मत. And now can anybody tell me what is the karyotyping? What is the karyotype? Thank you, Mama. What is the karyotype? What is the karyotype? What is the karyotype? Yes, Mullerian genesis is 46XX. And this is, अरे ये तो लड़की नहीं, ये तो लड़का है. Okay, but genitalia at birth look like a female, so she is read up as female only when you make. Okay, so this is XY, and that is why here the gonad present is ovary, and here we have testes. But testes is in the inguinal region, undescended. Testosterone cannot work over here. In androgen insensitivity is a receptor level problem. The testosterone cannot work. Okay, testosterone cannot work, and therefore the main important clue in the exam is your axillary and pubic hair. Axillary and pubic hair is what you check, and here it is very well present, and here it is absent. So I hope this one table will help you solve lots of MCQs. Breast is not a difference. Breast is well developed in both of them. Okay, breast will be positive over here also, there will be positive over here also. Okay, how many of you have seen that house? Okay, MD house. Okay, abhi mat dekhna, exam ke baad dekhna. In that they are like super models. Please understand this. By androgen insensitivity, by looking at the patient, you can never say कि इसको androgen insensitivity है. Height, weight, body curves, breast development, all like a perfectly normal female. So they are like a perfectly normal looking female, and they can become models and supermodels also. Okay, so please look over here, and in fact that house MD1 episode shows model only. Okay, so you need to keep in mind sir, breast is well developed. Okay, and absence of axillary and pubic hair, very good. Androgen insensitivity is the answer. Okay, the full form is complete androgen insensitive syndrome, and this lump felt in the inguinal region is the undescended testes. Is this understood to all of you? So please don't make a mistake. This is a very, very important thing. And then in Ritabrata, what can happen in partial will have ambiguous genitalia. Partial androgen insensitivity, very difficult, absolutely PG level. Some androgen can work, some androgen cannot work. So they can have a bifid penis, to some ambiguous genitalia, to they can have Riefenstein syndrome. That's all the things are there. Okay. Yes. Okay. Now, 16-year-old, primary amenorrhea, short stature, shield-shaped chest. So what is this? Yes, sir. This is when you have short stature, high arch palate, and specifically because estrogen shield-shaped chest, this is your Turner's syndrome. And in Turner's syndrome, the clue many students feel is a Turner's syndrome, absent uterus. No. Yes, please understand this कि सर इन टर्नर्स सिंड्रोम यूट्रस होता है, लेकिन टर्नर्स सिंड्रोम में प्लीज पे अटेंशन, ovary is not functioning. There is streak ovary. Ovary is replaced by fibrous bands. And therefore, yes, very good Tirth Modi, uterus hota hai, uterus is present, lekin chintu uterus is underdeveloped hypoplastic uterus. It is not absent uterus. Absent uterus, I told you only two conditions. So it is not normal ovary, it is not undescended testes, it is streak ovaries, but not absent uterus. Very good. Absent uterus is wrong. It is streak ovaries and a hypoplastic uterus. That is your Turner syndrome and 45X. So yes, is this understood? And this is one of the most popular short MCQ. ये वाला क्या है? Again a image. So lots of image we are discussing. So this is your classical cyclical abdominal pain. Patient will come to you and they will come to us with primary amenorrhea, which is actually your hidden cryptomenorrhea. Cryptomenorrhea is a hidden, very good, and imperforate hymen is the answer. Imperforate hymen, because why? In this picture we are seeing a bulging bluish hymen. Okay, we are seeing a bluish purplish and bulging hymen, and rightly told by all of you, you just take a cruciate incision. Okay, please understand this. Transverse vaginal septum can also present anything. This is a outflow tract obstruction, but in transverse vaginal septum there will be no bulging hymen. Transverse vaginal septum is at a higher level, so yes, it's at a higher level, so blood will get accumulated behind in a transverse vaginal septum, but then you don't get a bluish. Okay, so this blood is called as hematocolpos, and then this blood is called as, this is called as hematometra. Okay, what happens in this is your, yes, so in your, yes, whenever you have a imperforate hymen, in imperforate hymen there is a bluish purplish bulge. Okay, tense bulging hymen. That is how you say that, sir, this is a imperforate hymen rather than a transverse vaginal septum hidden. And can anybody tell me PG level, what is the long term complication of this condition? What is the long-term complication of this condition? The blood will go backflow. The blood will go backflow. So these patients have got increased risk of which condition? PG level. Absolutely. Clap if you have learned something new. The patients of imperforate hymen, long-term complication. Thank you, Mohammed Shagu. Thank you very much. Love you for that. Thank you. Tell all your friends and colleagues and junior about it. Also, yes, very good, sir. Long-term complication of this condition: backflow, retrograde menstruation. These patients are at increased risk of having endometriosis. So all those who haven't yet downloaded the app can quickly get in touch with me, WhatsApp me on this number. And just as I told you, my dear student, you just require one day. Abhi bhi time hai. We are still today only on 2nd of January. Don't miss out this opportunity. You will just require 8 to 10 hours. Just by doing 8 to 10 hours, you will finish like this kind of a similar only MCQ with detailed explanation, and you will get must know all the MCQs with beautiful handwritten notes just at 570 rupees. So download the OGGuru app and join today itself for the maximum marks in OBGY is my guarantee. It will become your most favorite and most scoring subject. All FMG, you can read all the testimonials, will not waste time over here, showing you all the love and appreciation the students have given. And just 1 second, look at this so beautiful, completely colored handwritten notes with integrated images. Just 2 hours. Every student has told, okay sir, once we see all MCQ, in 2 hours we can revise the entire notes. So notes also you are going to get in the app, for in reading in the app, and quickly all of you can download the app also if you haven't. and enroll after the class is over. Okay, moving on to the next very important topic, short topic, MTP contraception. Now can anybody tell me what are all used for emergency contraception except emergency contraception except? Yes, chalo. No, IUCD is definitely used, except, okay, so in emergency, you need to keep in mind, all of you going wrong. Emergency contraception कब use करना है? फटा condom, okay? Condom ruptures during intercourse, or boyfriend girlfriend meet, they have no plan of having sex but they'll end up having sex, okay? So yes, very good. Okay sir, for emergency contraception we have something when the patient comes to us within 72 hours, then what normally or the most common we use, all of you know the brand name iPill. But iPill क्या होता है? iPill is a brand name, but iPill क्या होता है? Yes, iPill is a single tablet of 1.5 milligram LNG. Okay, is it clear to all of you? And something very latest which you should know, up to 5 days if the patient comes to us, very good, IUCD is used and a latest new drug has come. What is the new drug which has come? That is your Ulipristal. Okay, Ulipristal, anybody, is what kind of a drug? Short new MCQ. Ulipristal, very good sunshine, selective progesterone receptor modulator. Absolutely virgin. What is the dose? What is the dose? Not old beta. Ulipristal is very new. Ulipristal is very new. Yes. So LNG Ulipristal ka dose you will tell me. Answer is misoprostol. Very good. Misoprostol is for MTP, which also I will teach you now. But Ulipristal dose. Yes. Ulipristal sir, 30 milligram stat. Okay. 30 milligram stat is the dose for emergency contraception. Excellent. Okay, excellent. Okay, but there's no non-hormonal. Okay, so there is, everything is hormonal, there's no non-hormonal. IUCD you can go as non-hormonal. Okay, is it clear to all of you? Now can anybody tell me, but how IUCD? Because IUCD works in emergency also. Yes, it's you should have known this concept because implantation takes place on the 6th day. Okay, so up to 5 days IUCD can also be used, and now this Ulipristal drug is available. It's a new thing, latest thing. Yes, IUCD up to 5 days. Very good. Now can anybody tell me one more use of Ulipristal? By the way, Ulipristal का one more use क्या है? Which another condition Ulipristal can be used? Okay, so by the way, remember Ulipristal can also be used in fibroids. Okay, Ulipristal not so popularly used, but Ulipristal, one is emergency contraception and it could also be used for fibroids to decrease the size of the fibroids. No, Vienna Violet up to 5 days. Okay, yes, very good. Deepak Kumar Singh. Okay, it can be used to decrease shrink the size of the fibroid. Doses will not be asked to you, but 5 milligram to 10 milligram tablet can be given to shrink the size of the fibroid. Okay, decrease the fibroid size. Clap if you have learned something new on a Thursday evening, and OG in the chat box and clap and hearts. Okay, so Ulipristal is not only your selective progesterone receptor modulator, it's a emergency content, also can be used in fibroids. Okay, yes. So the answer, Beta, within up to 5 days. Okay, 5 days. Any emergency contraception is only up to 5 days. Yes, ulipristal can also be taken within 72 hours. You are correct. Ulipristal can also be taken over here also, but within 72 hours, IPL is preferred. IPL is preferred, or it is the most commonly used. Most commonly used. Again, if that question comes. Okay, is this understood to all of you? Yes. Now, what is this device and what does it contain? Again, image based virgin MCQ, never asked till now, will come in the MCQ. Is this copper? Is this copper containing? This is a completely white color device which is going to have a hormonal barrel, and this is your levonorgestrel intrauterine device. The mistake, yes, it is LNG 52 milligram, and very good, also called as Myrina. And why I call it LNG 20, anybody? Because 20 microgram per day is released. Okay, which one can I explain? What better, Mohammad Faisal, what you want? Yes. Okay, so sir, this is a there's no copper. Okay, so it's completely white color device. It's a barrel which contains the LNG, levonorgestrel, and 20, very good treat. Okay, 20 microgram per day is released in the uterine cavity, and it is also very beneficial for menorrhagia because it decreases the growth of the endometrium. Okay, so keep that in mind. Can anybody tell me, for the apart from it is for contraception, but non-contraceptive benefit? Non-contraceptive, you have to be quick because I want to discuss more MCQs. Yes, very good. So because of continuous progesterone, okay, it is releasing continuously progesterone. It can be used in prevention and treatment of endometrial hyperplasia, and it's also used in patients of heavy menstrual bleeding. It will make the patient less bleeding will keep on becoming less. So I can use it in patients of menorrhagia. It is used in treatment of menorrhagia. Okay, yes. Now, very important new. Can anybody tell me? MTP Act now, the MTP now is allowed till how many weeks of gestation? Okay, so now, yes, very good. Okay, so now, sir, very good. 20 was the old answer. The MTP is allowed till 24 weeks of gestation. Keep this in mind. And how many doctors have to certify? Okay, so now again, one more thing, please keep in mind. Okay, ध्यान से सुनेंगे. चलो, now this question, all of you. Okay, this question. Patient has come to the OPD at 22 weeks with occipil failure. Yes, and therefore the students say कि sir अभी तो आपने बताया कि it is till 24 weeks, and therefore they will say it can be done. Wrong. Is this understood? Clap, ठोको ताली. Okay, why this is wrong? Because sir, this 20 to 24, it was till 20 weeks, it is increased till 24 weeks. This increase is only in cases of some fetal anomaly. Okay, if the baby has some anomaly, structural genetic problem in the baby, or if sexual assault victim, only in special cases, like they have said that if there's divorce in pregnancy, mainly rape victim. Okay, so if it's a rape victim, or if mother's life is at risk, or any fetal anomaly or genetic problem in the baby, yes, then till 24 weeks is allowed. Remember the very important failure of contra, and therefore this MCQ is surely coming. You are going to remember me on the day of the exam. Failure of contraception is still only up to 20 weeks. This is a PYQ. 100% repeat होगा in the upcoming exam. And therefore here, sir, when the patient is 22 weeks, sorry sir, I cannot do it, not permission of medical board, all that. Yes, but if any anomaly is detected in the fetus, then yes, that is the answer. Why? Because here it is occipital failure, contraceptive failure. So many books are giving wrong answer. Don't follow that. Follow what OGGuru is telling you. Contraceptive failure is still only up to 20 weeks. Okay. Is this clear? Yes. No, board permission is not required, beta. In board permission is only beyond 24 weeks. Okay. Medical board is involved only if it is beyond 24 weeks. Okay. Is this clear to all of you? Yes. Fetal anomaly 22, then you need, yes, very good, Bahamari. Yes, yes, yes. No, we can't do it anytime. If it's beyond this, then you have to do. Yes. Yes, at 20, very good. Okay. Yes, very good. Okay. So please keep this in mind. And this is again very, very sure. 45 days MTP patient has come to you. What is the regimens? Yeah, life saving is any. Okay. 45 days. So up to 63 days. Anybody, what is the regimen? थैंक यू यूजा यस ओके सो डायरेक्टली स्टूडेंट मार्क करता है मिफिप्रिस्टोन मिजोप्रोस्टॉल आंसर ए इज द आंसर रॉन्ग ओके यस सो अगेन प्लीज कीप इन माइंड श्योर शॉट एंड यू विल लव द ट्रिक विच आई एम गोइंग टू शो यू यहाँ पे कैसा है इट इज अ कॉम्बी किट 4 tablets what is this first tablet the first tablet what we give is मीफीप्रिस्टोन कैसे याद रखना है एफ क्लैप इफ यू फील हैप्पी फर्स्ट में आता है एफ एफ स्टार्ट्स फर्स्ट स्टार्ट्स विथ एफ द ड्रग विच इज एफ इज टू बी गिवन फर्स्ट it is 200 milligram single tablet anti-progesterogenic action anti-progesterogenic it is 200 mg and after 48 hours we give the second drug which is meso again clap if you feel happy meso mein aata hai s and that's why it is the second drug to be given so don't make a mistake many students write meso first no meso is not first so that is out meso is not first so that is out okay and here also it is wrong because the units are wrong okay so please keep this in mind the units are wrong okay so here we have 200 milligram here you can see 4 tablets just yes okay so please keep in mind all this okay all this is and this is how you will keep is 4 tablets each is 200 microgram each is 200 microgram and therefore here we give it either 800 microgram we can give it vaginally pv okay you give it pv okay or we will give it also orally or sublingual but when you give oral sublingual lot of nausea vomiting so pv route is preferred okay is this understood to all of you so please keep in mind 200 microgram into 4 so that is 800 microgram anybody again one more mcq what is the what is the what is the uh, success rate of this what is the success rate of this Dr. Puneet Mishra, it's not 200 milligram. This each tablet is 200 microgram. Okay, is this crystal clear to all of you? Okay, is it clear? So the answer is this: mifepristone 200 milligram, misoprostol 800 microgram after 48 hours. That is the answer. No, Manju Sen, very, it is absolutely superb method. Up to 60, the success rate is actually, books mention 96. In our practice we are giving it since we are aging so many years, we are using it. 98 to 99% success almost we are getting. Okay, so highly successful method. And you have to repeat sonography. Okay, you have to repeat sonography after. So again, a new MCQ, Thokotali, virgin MCQ, new thing what you are getting. Okay, new information. Okay, is it clear to all of you? More than that. Okay, and how do we generally tell the patient? You need to repeat the scan. Okay, you need to repeat the ultrasonography generally after 14 days to make sure everything is clear. Okay, vaginal infection, short topic, question aane hi wala hai. Anybody quickly, what you need to keep in mind in the topic of vaginal infection is your candidiasis, trichomoniasis, and bacterial vaginosis. Anybody, what is the organism? What is the organism? Short MCQ, don't make a mistake. Organism for the first column, second column, third column. Yes. So the Candida albicans is the organism. Trichomona vaginalis, and what is for BV? Gardnerella is the organism. Okay, Gardnerella is the organism. Now, can anybody tell me what is the type of discharge? What is the type of discharge in candidiasis? And a virgin image is coming up in the next 2 minutes. ध्यान से बैठे रहना. Candida albicans में you will get your curdy white or cheesy white, or also called as cottage cheese white. Cottage cheese matlab paneer. So anything to do with your dairy products, paneeri white, buttery white, okay, lassi white, vanilla white, shahi paneer butter masala, वो कुछ भी आया तो candidiasis ठोक देना. Okay, trichomoniasis is your greenish yellow, and here you get is grayish white. Now, can anybody tell me what is the whiff test? What is the whiff test? Irregular bleeding can happen. Yes, we are going to the drug of choice. We are coming in 2 minutes. Okay. So whiff test is positive in what of that? Okay. So when we take the vaginal secretions, and if to that I add 10% KOH, we will get a fishy odor because of release of amines. That is the positive whiff test. Absolutely one of the most frequently asked MCQ in the history, and that positive whiff test is positive only in bacterial vaginosis. And one more point we need to keep in mind is that I'm coming to the drug of choice. Here the acidic, which pH? The pH here is less than 4.5. Acidic pH favors fungal. Trichomoniasis, the suitable pH is 5.5 to 6.5, and bacterial vaginosis, the pH is generally more than 4.7. Okay, And I will also tell you, yes, we are coming to AMCEL's criteria. Very good, Mohammed Asif. And can anybody tell me the drug of choice coming up in a minute? So this is secretions plus a fishy odor. Is this whiff test is positive in which? In Gardnerella. Gardnerella or in bacterial vaginosis. Okay, yes. Now can anybody tell me, come on, ये क्या है? चलो. Virgin MCQ. Yes, yes, very good. And in which of them the, yes, so what is this picture? What is this picture? Yes, we are coming to, yes. So sir, this is your which fruit? Yes. So these are punctate hemorrhages, the cervix. So this is your strawberry cervix or strawberry. Also we get a strawberry vagina also. But this is a cervix picture. So this is the anterior lip, this is the os. Okay, the os is anterior posterior lip. You get multiple punctate hemorrhages, and this is very good. Not all of the above. Okay, this is trichomoniasis. Okay, remember this in mind. Trichomoniasis, we get strawberry cervix. And for trichomoniasis, the drug of choice is metronidazole. And I have to treat both the partners. Okay, keep that in mind. And what is this? What everybody was telling me? AMCEL's criteria. So again, short. AMCEL's criteria, all except. Okay, so yes, great white discharge, positive whiff test, and presence of clue cells. Okay, clue cells are nothing but the vaginal epithelial cells. Okay, they are the vaginal epithelial cells loaded with the organism. Loaded with the organism. So that is also the part. Option number C is the answer. Just see how the sign. Okay, pH is not less than 4.7. It is more than. So एक sign आपका जिंदगी बदल सकता है. Please keep in mind. Okay, so please keep in mind this can happen, so don't make a mistake. Yes. Okay, so vaginal pH is not less than 4.7, pH is more than 4.7. And again, for this, the drug of choice, what is this? Yes, positive whiff test and grayish white discharge, metronidazole. Okay, metronidazole is the drug of choice for this condition. Yes, excellent. Okay, and remember here, bacterial vaginosis, the partner treatment not required. So this is because of imbalance. It's thought to be because of imbalance between the good and the bad bacteria. Okay, so yes, here also metronidazole very popular. So these are short MCQs. You'll remember me on the day of the exam is my guarantee. Okay, now important point over here to be kept in mind for this is, can anybody tell me two things? What is the difference between gestational hypertension, preeclampsia, and chronic hypertension? Can anybody tell me? Yes, very good. Okay, so how do I differentiate between the gestational hypertension and preeclampsia? So gestational hypertension is only when the blood pressure is more than 140 by 90, but there is no, yes, but there, no, all of you, wrong. Okay, there is no proteinuria. Yes, no proteinuria. Of course, both of them are only after 20 weeks. Okay, no. Okay, very good RSR. Okay, yes. And pre-eclampsia में sir, it is high blood pressure plus proteinuria. Very good. Okay, but after 20 weeks only. Okay, there is proteinuria. If on that patient gets convulsion, we call it as eclampsia. And chronic hypertension, yes. Three definitions. Clap if you learned something new. Three definitions. Either the blood pressure is high before pregnancy or before 20 weeks. Is this understood to all of you? Okay, yes, excellent. So please keep this in mind. Okay, one, if the BP is high before pregnancy or before 20 weeks. But one more point, yes, what happens to blood pressure in both these conditions after delivery? Yes, excellent, existing, yes. After delivery, in gestational hypertension preeclampsia, delivery is the definitive treatment, and therefore the blood pressure will return back to normal. But when? Anybody? If I have a patient of gestational hypertension or preeclampsia, remember, delivery is the definitive treatment, and once I do the delivery, once we do the delivery, the BP will be, yes, become normal. But when? Yes, very good. Dr. RSR, 6 weeks was the old. Clap if you have written, if you have again learned something new on a Thursday evening. Dr. Anand Shamak, very good. That's sir, within 12 weeks. Okay. Okay, the blood pressure should return back to normal by 12 weeks of delivery. Okay, within 12 weeks. Okay, within 12 weeks of delivery, the blood pressure should become normal. That is very, very important. Okay. So chronic hypertension, you also have one thing that sir, if the blood pressure, you have a patient who is having hypertension or preeclampsia and BP is high even after 12 weeks. Okay, even after 12 weeks. Okay, a patient of preeclampsia and the BP even after 12 weeks postpartum. Okay, so this is extremely important. Please don't make a mistake in this. It's either the blood pressure high before pregnancy or before 20 weeks. Now, can anybody tell me what are the dangerous? What are the dangerous signs and symptoms when a patient is having? They are called as what? In a patient of, and why do I call it dangerous? They are called as premonitory symptoms. And now all of you tell me the diagnosis of this and tell me the answer. And two confusing MCQs back to back I'm giving you and tell me the answer. Yes, anybody? Blurring of vision? Yes, very good. What? Now tell me the diagnosis. Okay, we have got a patient who is having headache, blurring of vision, BP 180, 110, oliguria. Next immediate line of treatment is, chalo everybody. Yeah, I will teach you. Okay. Yes, I'll teach you that picture. Okay. Tell me the answer. And now, how does the question change? How does the question change or the answer change? The question here is next immediate line of treatment and what is the answer over here? What is the answer over here? Headache, blurring of vision, BP 180, 110. And for the definitive treatment is. Can anybody understand the difference in both the questions? And we are coming to that. Yes. Okay. So now please understand this. Please understand this, that the dangerous symptoms are why they are called dangerous, because they indicate impending eclampsia. In a patient of preeclampsia, they indicate impending eclampsia. कैसे याद रखना है? OB, OBS, easy है ना? Why? Because मैं हूं ना, शाहरुख खान. Okay, मैं हूं ना, तो OBS easy है ना. Clap if you feel happy. So OB easy है ना. O is your oliguria. B से है blurring of vision. E is epigastric pain. H is headache. Thoko tali, clap. OG in the chat box. And N is your nausea and vomiting. So any of this combination, generally in the question paper, they will give you 3 out of 4, 5. 1, 2, 3, 4, 5. Please by heart this 5. 5 dangerous signs and symptoms. And whenever we have this patient of impending, so your diagnosis here is impending eclampsia. You will never wait and watch. Anybody, what is this drug? Atosiban. What is atosiban? What is atosiban? Anybody? Sir, atosiban is a tocolytic agent. It is got no role. It's a tocolytic. It's a oxytocin antagonist. ACE inhibitors have got no role and I don't give it. Is this understood to all of you? Yes. And direct, the question here is next immediate line of treatment. I will give magnesium sulfate and labetalol. Now why labetalol? To control the blood pressure, but why magnesium sulfate? Magnesium sulfate, why? Because please understand this, even in patients of impending eclampsia, even in patients of impending eclampsia, in patients of impending eclampsia, I have to give magnesium sulfate. It has been proven beyond doubts that magnesium sulfate, when we give, it is going to prevent convulsion, prevent complication. Okay. Okay, it is going to prevent complication in patients of impending eclampsia. So magnesium sulfate, yes, very good. Not here, not neuroprotection, never had neuroprotection to baad mein hai. It is mainly, so here we give it prophylactically. So this concept many students do not know, that we are giving prophylactic magnesium sulfate. So that is the answer, that the next immediate line, I will give Maxsulf for prophylaxis from convulsion for the mother, and neuroprotection for the baby is separate. Okay, Navrat P. And labetalol of course is given, it's the anti-hypertensive of choice, because here the patient BP is 180, 110. So magnesium sulfate will be given, no role of enalapril, and the next immediately I do first is Maxsulf and labetalol. And now please understand this, but Maxsulf is not the definitive treatment. What is the definitive? The question over here is the definitive treatment is what? Now please understand this, the patient is only 32 weeks. So please understand this, के जो आपके हिंदी पिक्चर में ये हम बता रहे हैं, yes, okay, here the answer will be C. Okay, yes. Yeah, because beta, the question is why not C? Because the question is the next immediate line. Okay, next immediately I have to give myself and labetal. You will come to know when you play. Okay, now please understand this. Let the patient be 30 weeks, 32 weeks, 34 weeks or 36 weeks. Okay, or let it be 24 weeks or 26 weeks or 28 weeks. The answer will not change. तो हम जो बोलते हैं no lung maturity not required, I'll explain to you the picture. Okay, please understand this कि माँ और बच्चे में से किसको बचाना है. डॉक्टर लेबर वार्ड के बाहर आता है, हिंदी पिक्चर, फेमस डायलॉग, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Okay, that is a stupid dialogue that cannot be told. Okay, because in obstetric it is always mother first. So please understand this. Whether the patient may be whatever weeks, you will never wait and watch, because if you wait, okay sir, let me wait for lung maturity. Okay, so those who said, sir, wait for lung maturity, Jimmy Patel, that is wrong. Okay, you never wait and watch because the mother will die. So magnesium sulfate is to be given, but delivery has to be done, because please write down, delivery is the definitive treatment. ओके फिर माँ और कोई बचेगा, कोई बोलेगा डॉक्टर को बचाओ, कोई बोलेगा सर माँ को बचाओ, कोई बोलेगा टाइगर को, इंडियन को टाइगर को बचाओ, चीता को बचाओ. हम लोग बोलेंगे पहले डॉक्टर को बचाओ. ओके, सेव दिस. ओके, so never wait and watch. I have to do the delivery, and here also we prefer induction of labor first, because delivery is the definitive treatment. Most important words in the brackets: irrespective of weeks of gestation. Irrespective of weeks of gestation. Is this always understood to all of you? So here the question is next immediately Maxel labetalol. And now when we come over, now tell me the answer. Maxel, very good. But deliver at 37 weeks. Sorry, I will have to go to jail. Why I will have to go to jail? Because we are 32 weeks. Okay, that means it is telling me to wait. It is telling me to wait till 37 weeks. Sorry, again wait and watch, go to jail. Okay, and therefore again don't deliver, wait till 37. Controlled preeclampsia we can wait. Okay, so induction of labor, of course Maxel will be given. Labetalol will also be given, and the answer over here is made crystal clear, because the question over here is, please read the MCQ. The definitive treatment is what? So the difference between the two MCQ, I hope all of you have understood it if you have paid correct attention. Okay sir, here the question over here is next immediately what do I do? So sir, next immediately we give max self, but delivery is the definitive treatment. Okay, now everybody wanted the Pritchard regime. मैं हूं ना. Magnesium sulfate by Pritchard regime, the total dose is 14 grams. Okay, it is 14 grams. 4 gram is given IV and 10 grams is given IM. Okay, but 10 grams is a high dose, so you don't give together. We give 5 in one buttock and 5 grams in another buttock. Is this understood to all of you? So remember, max self by Pritchard regime is a 14 grams. 14 gram, 4 gram IV slowly, followed immediately by 10 grams in each buttock, 5 gram plus 5 gram in each buttock. Okay. Okay, is this understood to all of you? Very good. And very important, the therapeutic range to be achieved is how much? The therapeutic range is 4 to 7 milli equivalents per liter, because if the level, yes, and what all things you monitor, we have to monitor when I give the Pritchard regime. We monitor the deep tendon reflexes or the knee jerks, respiratory rate, and urine output. And how much should be the urine output? 25 to 30 cc per hour. Is this understood to all of you? Yes. And magnesium sulfate toxicity, calcium glucose, all of you know these points. Okay. Is this understood? So quickly, all of you, please do not waste time. Just take 1 minute, start following me on Insta every day. Lots of MCQs are coming up. I'm putting, and start following me on YouTube for this wonderful session. Even after your FMG examination, those who are giving FMG in June and December can take the 6 months master class and 12 months master class. Also, the session notes will be available. So join on Telegram also, and do follow me on Insta and YouTube for lovely content which you're going to get. And do not forget to subscribe to the OGGuru app and get in touch with me on phone and WhatsApp. And just 1 day time, you can revise the entire OBGY is my guarantee. Okay. So quickly, just subscribe, follow me on the YouTube channel of OGGuru. Lots of video is already there, and you can also revise the content from there. वेरी इंपॉर्टेंट टॉपिक, एक ही टॉपिक, एक्टॉपिक प्रेगनेंसी. मेरे स्टूडेंट बोलते हैं सर एक टॉपिक, सर कोई भी एक टॉपिक तो पढ़ा दीजिए. ओके, सो एक टॉपिक इज योर एक्टॉपिक प्रेगनेंसी. ओके, and that is your ectopic pregnancy. Now anybody, what is the most common site? Okay, what is the most common site, and can anybody tell me? Okay, so please understand. So beta, in IM we give undiluted, and IV have to dilute it. Okay, we take 8 ml and you dilute it with your 12 ml of saline. Okay, so beta, that is absolutely PG level. I've discussed it in my actual classes also. Okay, Kriveri, that you take 8 ml of magnesium sulfate, dilute it till 20, diluted with 12, so it becomes total 20 ml, and 20 ml is given slowly. Okay, is it clear, Kriveri? So 8 ml and dilute it to another 12, so make it total 20 and give it slowly. Yes, very good. The most common site is the ampulla, followed by the isthmus. Okay, yes. So now please pay attention. What are the risk factors for development of ectopic pregnancy? All except. So this is your PID, pelvic inflammatory disease. Okay, yes, very good, Medico Anand Sharma. Please understand this, that when I have to keep about the risk factors, pelvic inflammatory diseases, gonococci, chlamydia, it's a very important risk factor along with my genital tuberculosis. So that is there. Past history will always play a role, and any tubal surgery if I have done, it can also cause ectopic. The answer is OC pills. OC pills are protective. OC pills are protective. Why? Because they make the cervical mucus thick. No, beta. Dr. Punit, I'm coming to it. IUCD is a very big, important misconception. I'm going to remove it, and please clap if you feel happy. Point number 1, note down all the methods of birth control which make the cervical mucus thick. What will happen if the cervical mucus thick? No. Okay, yes. No. Medico, wrong. Myrina, okay. So all the methods of birth control which make the cervical mucus thick. Anybody, what will happen if the cervical mucus is thick? So if the cervical mucus becomes thick, any infection in the vagina, the infection in the vagina cannot go up. The infection in the vagina cannot go up, and the tubes remain healthy. Tubes remain healthy, and the PID, pelvic inflammatory diseases episodes are going to decrease, and therefore ectopic pregnancy also will decrease. And therefore please understand this, OC pills, POP, DMPA and Mirena, all are protective for ectopic. ठोको ताली, all are protective for ectopic. तो बाकी जो भी आपने कहीं पे भी पढ़ा है, कचरा डस्टबिन, tear the page and throw it in the dustbin. Is this understood to all of you? Occipils, POP, DMPA, Mirena, all are going to be protective for occipils. And similarly, please understand this, IUCD, if inserted with all, IUCD is bichara unnecessary blamed for ectopic. IUCD does not increase the risk of ectopic pregnancy. Okay, is this? Yes, IVF is a risk factor. Okay, IVF is a risk factor. But keep in mind, not IUCD, but yes, IUCD if you have not taken proper precaution. If IUCD you have dipped in a mud and it causes PID episodes, so then it's PID which is causing more ectopic. But IUCD failure, yes, IUCD failure, if it is there, then IUCD failure, there is increased risk of ectopic pregnancy. IUCD failure means, yes, very good, creating happiness. Yes, okay. Yes, okay. IUCD failure, that means the patient is यहाँ पे ऑलरेडी IUCD डाला हुआ है. IUCD failure means patient has conceived, patient becomes pregnant. तो ये बोलेगा कि मैं यहाँ पे बैठा हूँ, तो then ectopic chance is more. Is this understood to all of you? So clap if you have learned something new. So IUCD failure means there is IUCD and pregnancy, then yes, ectopic chance is more. Okay, is this understood? So don't make a mistake in this. Now again, tell me the diagnosis. Tell me the diagnosis. Okay, so the diagnosis over here is shock in early pregnancy. Patient has come to us with 2 months amenorrhea and shock. Why shock? BP 90/60 hemoglobin. Next immediate line of treatment. Okay, next immediate line of treatment. Okay, so here remember, this is your very good, this is ruptured ectopic pregnancy. Ruptured ectopic pregnancy hai, very good. Okay, so here please understand this, why ruptured ectopic. All of you will note down the dictum, shock in early pregnancy. Okay, when it is shock in early pregnancy, think of ectopic first. And why early pregnancy? Because we have got 2 months amenorrhea. Beta urine test is positive. Please understand this. Those who we don't have time to repeat beta HCG after 48 hours, you'll have to go to jail. Patient will die. Patient will die of shock. Okay. So here when the patient, we are not going to repeat beta, that is in patient of unruptured ectopic, or when we have doubt whether it's an intrauterine or extrauterine. Yes, very good, hypovolumic shock. So here remember again, we have got two things. One is the immediate treatment and second is the definitive treatment. Now can anybody tell me what is the immediate treatment? Very good. And what is the definitive treatment? What is the definitive treatment? Very good. So please understand this, my dear student. Immediate treatment is, I put in 2 wide bore IV lines and I have to collect blood for cross match and I have to start IV fluids. That is the emergency resuscitation. So that is what it is. Let's collect blood for cross match and start IV fluids. That is the answer. Methotrexate has got no role over here in ruptured ectopic. And very good, excellent. And this has to be immediately followed by option A, laparotomy. And laparotomy में हम क्या करते हैं? Quick in, quick out. Remember, salpingectomy. Salpingectomy is the gold standard surgery. Don't feel sad that, oh, I'm cutting off patients one tube. Another tube is, yes, both questions are slightly different, okay? Yes, the wording of the question. That's why I'm here to tell you why the difference, okay? Why not A, beta? Because the thing is, next immediate line of treatment before doing laparotomy, will you not start IV fluids? Will you not collect blood for cross match? Is it clear? What you're not getting, Dr. Raj? I'm showing you both the questions, will get clear, okay? Both questions are different. Yes, very good, spotted, Dr. Puneet. Okay, so here the question, please pay attention, all of you. नेक्स्ट इमीडिएट लाइन ऑफ ट्रीटमेंट, ये सेपरेट क्वेश्चन है. एंड हियर द डेफिनेटिव ट्रीटमेंट, इनिशियल पार्ट ऑफ द MCQ is same. See how they are confusing you in the exam. Okay, so in the immediate line of treatment, we have to go with 2 wide bore IV line, blood and cross match and IV fluids. Is this understood? And therefore the answer is cross match, blood and IV fluids. Of course, in practice everything happens together. In patient में, private practice में, या patient आपके OPD में, या in your emergency department, everything will happen simultaneously. But first I will put the IV line and then immediately shift the patient. Immediate treatment has to be followed by definitive treatment. Shift to the operation theater, and salpingectomy is the gold standard surgery, and therefore no methotrexate and no laparoscopy. Salpingotomy nahi hai, the whole tube, yes, that as a trap. And laparotomy and salpingectomy. Very good, this is the answer, laparotomy and salpingectomy. Why? Because all of you pay attention, that whole tube is stone. Okay, that whole tube is stone and tethered, and it is severely bleeding. So you cannot do ostomy. I need to get the whole tube out, then only the bleeding will stop. Okay, okay, is this understood? Yeah, but how long the class? Another half an hour more. Okay, yes. So that is why, remember, I have to do salpingectomy only. I have to do salpingectomy only, which is the same beta, first line and gold standard. Correct, I have it. Okay, so salpingectomy is the gold standard surgery or the definitive surgery in cases of ruptured ectopic. Please understand this, when it's a ruptured ectopic pregnancy, I have to go for the salpingectomy only. Salpingotomy and all that is kachra, we don't do that. Is this understood to all of you? Okay, the next thing what we should know is, what is your diagnosis here and what are we going to do over here. Okay, so here, my dear patient, we have got a 2 months amenorrhea, stable patient, pulse 80, BP 120/80, hemoglobin 11 gram percentage, and uterus is empty. So when the beta HCG is positive, uterus is empty, I have to look outside the uterus. And what are we seeing? Sir, we are seeing a 2.5 centimeter mass outside the uterus. Very good. That is ectopic pregnancy. Excellent. And this is unruptured ectopic pregnancy. And the answer is methotrexate. You don't need to, beta, all of those who are saying A, why? You will repeat USG after 2 weeks. Ectopic will rupture. Ectopic will rupture in 2 weeks time. Again, you have to go to jail. Okay, please understand this. Very good, doctor. Stable patient, unruptured, surgery is not required. Methotrexate is the treatment. Okay, please understand this. Whenever there's a confusion, whether it's a intrauterine or extrauterine or ectopic, then only. Okay, the confusion, remember, okay, when it is a there is we are not seeing when we are not sure if it's a intrauterine pregnancy or ectopic pregnancy, when there's a confusion, that is the time when I repeat the beta hcg after 48 hours. That's the only time we wait. Otherwise there is, yes, very good, HC repeat after, excellent Deepak Kumar. Okay, so that is the time when you repeat. You don't have to repeat USG after 2 weeks. In that 2 weeks topical lecture. So this is methotrexate fits the bill. Why? Because gestational sac. What is the criteria for methotrexate? Okay, we give intramuscular 1 milligram per body kg weight. Okay, so what is the criteria, sir? If the gestational sac, okay, if the gestational sac is less than 4 centimeter, most importantly, patient stable. That means it has to be unruptured ectopic pregnancy. And third, the HCG is less than 5000 micro international units per ml. If these criteria are there, we prefer to give methotrexate. And then after methotrexate, we can repeat the HCG levels. Is this understood to all of you? Yes, stable mother. Now tell me this, very, very important. Diabetes in pregnancy, screening for diabetes in pregnancy, ideally done at what weeks of gestation? Ideally, we do the screening, ideal time for screening is 24 to 28 weeks, because that is the time when the insulin resistance is maximum. And very good, we follow now the DIPSI guidelines. Diabetes in pregnancy. DIPSI stands for Diabetes in Pregnancy Study Group India, and 75-gram glucose is given with half a glass of water. And we will repeat the, we will not repeat, we will give the blood sugar after 2 hours. So 75-gram glucose with half glass water, and 2 hours के बाद the level should always be less than 140. If it is more than 140, then it is your gestational diabetes. Okay, so in DIPSI guidelines, again a PYQ shortly coming, 75 gram is what you follow. Okay, now tell me this. Chalo, trick MCQ. The most common anomaly in the baby of the diabetic mother. Yes. So please understand this, that those who are getting confused, okay, that the sacral agenesis or caudal regression syndrome is not the most common. Okay, this is the most specific. It is the most specific. Okay, very good. Okay, the most common overall is VHD number 1, followed by neural tube defect anencephaly number 2. So please keep in mind, very good. Okay, so keep in mind, my dear student, when they ask you most common is cardiovascular number 1 and your neural tube defect number 2. In cardiovascular, the most common is VHD. Clap if you have learned something new. Yes, by the way, the most specific cardiac, okay, if they ask you most specific cardiac anomaly, then transposition of great vessel or transposition of great artery is a specific cardiac anomaly. Okay, it's a cardiac. If they ask you the most specific, or they ask you the word MCQ uses classical. Okay, the word generally used in the question paper is the classical cardiac anomaly. Classical cardiac anomaly is your TGV. Is this understood to all of you? So don't get confused. Caudal regression syndrome is the most specific anomaly, not the most common. It is not the most common. Most common is VHD, and then anencephaly. TGV is very this. Okay, is this understood? And now a pediatric question. All of you should know that, again a PYQ, that baby ko kya hota hai after the newborn in a mother has got diabetes. Yes, keep this in mind, because after delivery, baby is having that hyperplasia of the pancreatic cells and insulin is more. So hypo, that's why we need to monitor the sugars in the newborn, and specifically if the mother is on insulin, hypoglycemia is very common in the newborn. Okay, not hyperglycemia, hypoglycemia. So please keep simple MCQ, but don't make a mistake in this. Okay, now very important. Can anybody tell me this? What is the anticoagulant what we are talking about? Heart disease. Heart disease, mitral valve replacement. So there is a metallic valve in the patient's body, and the metallic valve is oral anticoagulant she is taking. She is now 10 weeks. She is continuing. Doctor should have told her that as soon as you become pregnant, which is this oral anticoagulant. The oral anticoagulant which we are talking about is the warfarin. And can anybody tell me what can happen? Yes, and therefore in pregnancy. So all of you pay attention. When the patient is non-pregnant, we give warfarin. As soon as the pregnancy is confirmed till 12 weeks, we have to give heparin. Why? Because warfarin is absolutely contraindicated. Yes, warfarin is warfarin is absolutely contraindicated in the first trimester. What happens with warfarin? Very good. Conradi syndrome. Clap. And Conradi के लिए याद रखना है, Conradi starts with letter C. So the problem also is with letter C. Central nervous system and cartilage. Okay. Chondrodysplasia. Cerebellum. Cerebellar. All that CNS. Okay, is it understood? And optic atrophy, blindness, so baby can't see. So warfarin से होता है Conradi syndrome, and Conradi syndrome will affect the baby का cartilages and central nervous system, which is the answer over here. Okay, the baby will have Conradi syndrome. Okay, is this understood to all of you? Yes. After 12 weeks are over, from 13 weeks till 36 weeks, the patient can be back on warfarin, W. Okay, so it's WHW. And remember, around labor, because heparin short half-life, heparin does not cross the placenta. warfarin crosses the placenta. So after 36 weeks, again a PYQ surely coming this year. Okay. Okay. Better definitely better ABC, but also go for the app and 560 rupees, 10 hours more than enough to crack and get the best marks in OBGY. Okay. Rapid revision course on my OBGY app. Okay. After 36 weeks till delivery, okay, the patient will be on heparin. Keep this in mind. Again, shift to heparin. And last May, after delivery with postpartum, patient can ABLU be on again be on double warfarin. So clap if you feel happy. It is exactly alternate WHWHW. Okay, alternate WHWHW. Okay, this is very important. After 36 we have to shift over and give heparin, because heparin is a short half-life and does not cross the placenta, because baby can have internal bleeding and bruising. And after delivery, postpartum, you again go to warfarin. Is this understood? And the last topic, please pay attention, one of the most common, cervical cancer. Anybody? The number one cancer. The second most common cancer for ladies in India today. What is the first most common? Yes, breast cancer is the most common. So keep in mind, yeah, warfarin secrete will make better, but that's fine with breastfeeding, it's okay. Okay. Now, can anybody tell me what is the most common etiology for this and which are the risk factors? बेटा the same thing बेटा, ये पूरा बता दिया, prosthetic valve बेटा, Scrivery, this all this what I told you, cry very बेटा, all this what I told you was with the prosthetic metallic valve only. This is what I told you, this is pregnancy with metallic valve. Okay, prosthetic valve, that is what I told you. Non-pregnant, pregnant, heparin, WHWHW. Okay, already told to you. Yes, yes, very good, very good. Breast cancer number one, and not HPV, human papilloma virus, which is the most common. HPV. Yeah, after delivery you can give heparin, but then the warfarin is better, because heparin is an injection which you have to take daily. Warfarin is a tablet. Yes, very good. 16 is the most common and most specific. If they ask you, then mark HPV 18. Okay, so please keep all these questions in mind. They are really going to be helpful for your exam. Okay, is this clear to all of you? Now, please tell me, I'll give you the step-wise treatment, but before that, what is the answer over here? 33-year-old nulliparous patient, pap smear, abnormal colposcopy biopsy, CIN3. What is the next line of management for this patient in a 33-year-old nulliparous CIN3? Okay, and the next question which I will show you is again confusing for the students, is your this, a 50-year-old para 3 living 3, pap smear was abnormal, colposcopy CN3. What is the next line of management over here? Okay, now please pay attention. Okay, so first of all, the mistake which student make is CIN3 and CA cervix are not the same. Okay, CIN3 is cervical intraepithelial neoplasia. Can anybody tell me what is the difference between CIN3 and CA cervix stage 3? Same or different? Same or different? Okay, yes. So they are completely different. Patient first may develop CIN1, then CIN2, then CIN3, then carcinoma in situ. Till here the basement membrane is intact. And then when the basement membrane is ruptured, she may develop cervical cancer, stage 1, stage 2, stage 3 and stage 4. Is this understood? So CIN3 is still like a benign condition, whereas cervical, this is the actual CA cervix. So I hope that is crystal clear to all of you. Yes, stage 3 I'll also tell you how to keep. Okay, yes, so please keep in mind, when I have a 33-year-old nulliparous, if I do hysterectomy, I have to go to jail, isn't it? Because she's nulliparous. And CIN3 in a young patient, CIN3 in a young patient can be treated only with LEEP or LEEDS, loop electroexcision procedure. Yes, it is not benign, it is, yes, up to CN3 it's very good. Vienna violet management is like a benign condition, it's a pre-cancerous, it is not yet cancer. Very good. So the answer over here, in a repeat PAP we may can do in CIN1, we may want to repeat the PAP. Okay, so here the answer is LEEP, loop electroexcision procedure. Okay, and now when the patient is old patient, family complete, what will I do? Anybody? B, C, D, chalo tell me. This is a 50-year-old, para 3 living 3, family complete, and again CIN3. Okay, so the mistake student make is directly पढ़ा कुछ भी sir CIN and mark कर दिया Wertheim's hysterectomy. No, okay, please understand this. Radical hysterectomy or a modified radical hysterectomy is also called as Wertheim's hysterectomy. That's for actual cancer. Okay, and CTRT is also for cancer. Here I require only a simple hysterectomy. Simple means whatever route I operate. Okay, simple means it could be laparoscopic, vaginal, abdominal. That's not the case. Simple hysterectomy matlab ke sir, only the uterus and the cervix comes out of the body. Okay, only I need to remove the uterus and the cervix. No need to remove any lymph node, parametrium, all that lymph nodes, ovaries, parametrium, वो सब नहीं निकालना है. So simple hysterectomy means like any other benign condition. Is this understood to all of you? Clap if you have learned. Okay, so like any other benign condition, what I do is a simple hysterectomy and not, please write, and not a Wertheim's hysterectomy. Okay, yes, not a Wertheim hysterectomy, and that is the answer over here. Okay, sir, I will require only a simple, and modified radical hysterectomy is for actual cervical cancer, CA cervix, which stages also we're going to discuss quickly. Okay, so can anybody tell me the modified radical or the Wertheim's hysterectomy is for which stages of cervical cancer? Okay, so remember only my stages 1A, 2, 1B and 2A. Up to this stages only we can do a Wertheim's. Beyond this, stages 2B, 2, 2B, 3 and 4, 4A, 4B, whichever Roman letter you write or normal letter you write, also same thing, 3A, 3B, very popular MCQ, all will be treated by CTRT only. Very good. Concurrent chemoradiation. Okay, so when you say concurrent chemoradiation, or you say chemo radiation, all mean the same thing. So stages 2B, 3, 4 are all CTRT, and CTRT is the treatment because they become inoperable and I cannot do a surgery for them. Is this understood to all of you? Yes. So whether you call it chemo radiation or concurrent chemo radiation, that is the best thing. Okay. Now इसमें याद रखना कि you don't do a Verdems. Okay. So this is all about your CIN3 management, and stage 3 cervical cancer अगर आया, so please keep in mind CTRT is the best treatment. Okay, CTRT. Okay, only CT is wrong. RT or CTRT, which is given the option. Yes, cisplatin is given, very good. Cisplatin is given before, very good. But then main treatment is the radiation. But the word used is concurrent chemo radiation. Is this understood to all of you? So I hope and I request all of you to quickly take a minute and do follow me on the Instagram on OGGuru. Every day we're going to give out new this. Okay, beta same 2A be same now, 2A same beta till 2A. Okay, 1A to 1B till 2A we can operate. Okay, 2B ke baad it becomes inoperable. Okay, yes. Yes, chemo, Dr. Pund, correct. All stages, by the way, you are correct. That sir, all stages also we can give CTRT. Okay, all stages we can give CTRT is possible, but surgery is preferred. For this stages, surgery preferred because it can save the ovary. Okay, because with chemotherapy this. Okay, beta Vienna Volvet FIGO classification is not important. Only thing please keep in mind for sure, which is the question going to come in the exam, that cervical cancer will spread laterally. Okay, cervical cancer will spread laterally. Okay, and engulf reach the lateral pelvic wall, giving rise to hydroureter hydronephrosis, non-functioning kidney. That is CA cervix stage 3B. Please by heart this. Please by heart this. Okay, cervical cancer spreads laterally to the lateral pelvic wall, giving rise to hydronephrosis and stage 3B. Okay. Is this understood to all of you? So quickly, all of you, please subscribe to my YouTube channel. You will get lots of interesting content. Also do join the Telegram. Do follow me on the Instagram app. Every day, lots of new content is coming. Yes, Uremia, very good. Okay. And download the OGGuru app. Do not waste time. This is for the Android app and this is for the iOS, and the ORG code is YYMSTV, and you can download the app and get in touch with me on phone and WhatsApp on this number. Still time is there, as I said. Okay, there is only, you require 8 to 12 hours time depending on how much time you study, 1 to 1.5 days, and you will love it like this. How we had a 3-hour session, all MCQs, clinical case, images, handwritten with my personal doubt. Okay, in a molar pregnancy, you just have to remember the snowstorm appearance and the suction evacuation is the treatment of choice. Okay, is it clear to all of you? So this is the app and you can just quickly subscribe to it, and all these are the beta violet, all these 10 topics are the most important topics I've selected for all of you. Okay, so wishing you all, and yes, you can have a look at the beautiful handwritten notes and this PDF will also be available. So wishing you all the best. Don't take stress. My most important tip for the exam is read the question correctly. Today I have selected purposefully, I've given you some similar looking MCQs where I hope you are able to understand that what is the most common, most specific, what is the next line of management, what is the definitive treatment, all that you need to keep in mind. Okay, so all these are the most important topics what is selected: APH, PPH, forceps, vacuum, all this, ectopic pregnancy, cervical cancer, your these are the top 10 topics which are the most likely questions. Infection also guru and do, and definitely all of you can subscribe to the OGGuru app and all of you will do very well is my guarantee. Bye bye, best of luck, keep cool, keep calm, question ध्यान से पढ़ना, specifically in obstetrics. Look at the weeks of gestation, look at the fetal heart rate, because management will change when the weeks of gestation will change and this will also change. Yeah, thank you very much all of you. OG in the chat box, best of luck, and all of you will do very well in the exam, and do get in touch with me after your exams also for your preparation for NEET PG also. Okay, bye bye, best of luck, thank you very much, and I will see you soon in this. Okay. So, beta, Fatima Habib, lots of images were discussed today. You can go back and check the video. Lots of images like your HSG images, laparoscopy, chromoperturbation, PCOS, ultrasonography. Lots of things have been discussed. And furthermore, on the app also, there are special sessions for image-based MCQ also. Okay, bye-bye. Best of luck. Thank you very much. And we will be seeing you soon and wishing you all the best for the upcoming examination.